This conference will now be recorded.
Okay, this conference is now being recorded, and this is Rick Davis, and it is the 2nd. Yes, the 2nd. The 2nd of December. We're already at the end of the year. We hope everybody had a great Thanksgiving. Everybody who's here, everybody who listens in. You didn't overeat. I came up with a new dish, which turned out to be very good, but I was the only one eating it, so that's probably why it was so good. But I made a green chili with yams, and so it was like sweet and sour with tomatillos and yams, and it came out great, and it was healthy as well. None of those marshmallows and sugar and maple syrup. Of course, Len doesn't use any of that, um, but anyway, my if anybody wants the recipe, I had to write it out for somebody, so you can write me for the recipe. The secret is cook it slowly and on a low heat, and then it's really good. Okay, enough of that. Let's see. Um, Sponsors. Yes, thank you to all our sponsors. I will say the list is getting smaller rather than bigger, and we've got to do something about that next year. Um, the list currently includes uh, Johnson, Bayer, um, Novartis, Telix, Myriad, uh, Foundation Medicine. Who did I miss? Anybody? You guys know better than I do because I don't have it.
Novartis, did you mention?
I said Novartis, yes. I've
Blue
got
Earth.
Okay.
Blue Earth.
Blue Earth. Thank you very much, Captain. Um, so, except Blue Earth didn't give us any money this year, so that's one of the shrinking people, which allows me just to say that everybody will soon be receiving our annual fundraising letter, and we hope you treat us very generously to make up for the sponsors that are dropping off. So David Muslin is leading that charge, and we're getting very close. We should have a fun letter for you with some nice pictures from the year and a few good quotes, and I don't know what else. So um, I'm just I just do a little of the heavy lifting and then get out the way. Um, okay, so now we've taken care of all the housekeeping. We're going to start with Luther, and then from Luther, we're going to go to Bob, and we will hopefully get through everybody in the next 45 minutes and leave plenty of time for questions. So, Luther, I do remember you came in mid November, um, and we didn't have time to get to you as a new person. So, very glad you're back. Please tell me how old you are.
82
God bless you. And where do you live?
in Hernando Beach, which is about 40 miles north of Tampa, Florida.
Okay, another. Of course, my pencil decided it doesn't want to work just at the wrong time. So let's see if we can get it to work now. Hernando Beach, Florida. We have a few people. Where's my man Russ? Is Russ Hoover? Oh, Russ Hoover isn't with us today. He lives your way, and we have people in Tampa as well, and etc. What year were you first diagnosed, Luther?
Late 2016 with a DRI, in January 2017 confirmed after a biopsy.
Okay, and that biopsy, what was your Gleason score and what was your PSA level at the time of the diagnosis?
PSA was 6, and the Gleason score was a 9, 5.4. I always forget it was 5.4 or 4.5.
Well, unfortunately, it's quite a big difference.
I understand that, but I'm just telling you, I wouldn't want to give you that number right now and confirm it because I don't.
Okay, but you think it might have been a 5.4.
Yeah.
And where were you diagnosed, and at what institution, and was that?
Uh, that was through Celebration, Florida,
Okay.
Dr. Patel.
Ah, Dr. Patel. So did Dr. Patel actually diagnose you? Because he usually does the procedures. We don't hear him getting
Well,
involved so early.
it was kind of a combination at that time because once diagnosed through the biopsy, we were looking around as to what path to follow, and we interviewed a radiation guy and radiation or a hormone therapy guy, and I think the course of that led us to Dr. Patel. But I need to look back at the records as to who did the actual diagnosis. I think it was probably maybe a Dr. Khan that works with Dr. Patel.
Okay, so can I then assume that you did surgery?
Correct?
Okay, and so you did surgery at 76, were you at the time?
Yeah, yes.
Okay, good for you. Brave decision to do the surgery. Now, what sort of scans did they do before that surgery?
I had a PSMA which did not detect cancer.
That's great. Where did you go for the PSMA back in 2017?
Uh, yeah, gee, I wasn't prepared to answer all these detailed questions, but
It had to be a clinical trial.
no, it wasn't a clinical trial, but
Then
it
I don't
was.
think you had PSMA. It wasn't even approved until 2019.
Well, I had a PSMA, um, and it was actually a mobile unit that went around from hospital to hospital or clinic to clinic and conducted it through the machine they had set up in their trailer. But I don't know if it was through my oncologist or through my urologist.
I don't want to argue with you, but I do want to say that I don't think there were any mobile units at that time. There were very, very few sites you could get it. You could get it at UCSF, you could get it at UCLA. There was a site on the East Coast, I can't even remember where, but that was the PSMA scan. Now, you could get scans like you're talking about, MRIs and what have you, in mobile units. But back then in 2016, it was pretty hard to get a PSMA scan. We'll
It
leave
would
that
have
one.
been it would have been in 2017, but not to quibble over the date. But it was a PSMA, and the agent was an 18 something. I could be prepared next time.
F18. Yeah, I mean, well, maybe Len can do a little background. If there was, who did the who had the F18?
Well,
Blue Earth.
F18 is used for Axumin, and it's used for the bone scan, the PET bone scan.
Yeah, yeah, it
So,
is. But doesn't it wasn't Pylarify with a F18 agent as well? I think it is.
yeah, it is F18. But
Right.
I mean, I had to enter a clinical trial in 2019 in order to get PSMA. So
Yeah. Um, doesn't really matter. Did they find any indication of any metastasis, Luther?
Not at that point.
None at that point. So you went through the radical prostatectomy and with Dr. Patel, and what was the result of that? And what year? When was that? In 2017, same year?
Yes, May of 2017.
Okay.
Uh, he was satisfied with the results, negative margins, and everything else looked good.
So how? What was the result of your first PSA test 3 months later?
Undetectable.
And so tell us what happened after that. In
At
2000
the
and
same time, I got a Casodex shot and on Lupron
why did you get Casodex and Lupron if everything was successful?
because I was going out of the country back in January, and it was going to be a 4-month wait for Dr. Patel. So my urologist and oncologist decided to give me a Casodex and start me on Lupron to cover me for that period of time.
Oh, okay. So you did the Casodex and the Lupron before you had the surgery.
Yes, unfortunately, because then Dr. Patel informed me post-surgery that I would not be a candidate for the testing of the sample to see whether there was some hereditary conditions there because I had the Lupron already.
Yeah, but that again, that's whether you have Lupron or not is not going to affect whether you're tested for hereditary.
I may be using the wrong terms.
Okay. So maybe there were some other tests that he wanted to do that he couldn't do, but that wore off. I'm assuming that wore off. And what happened with your prostate cancer after the?
Approximately a year and a half, the PSA came back, low readings in the 0.5, 0.6, 0.7. At that point, I had advised to get radiation. The radiation oncologist determined that given there was negative margins to start with, that there was still a possibility that something was in the bed of the prostate that was still cancerous and that I should get radiation. So I had 36 treatments of radiation.
And did they accompany that with any more Lupron or not?
Yes.
For
And
how long?
Back on Lupron.
For how long?
Another 6 months.
Okay. So that roughly takes us through to about 2020, 2021. Would that be right?
Yes.
And then did you ever get that germline test done?
No.
Okay, well, it's probably a good thing to do even now. And we'll put a link in the chat window for you. Those are the two little boxes. And we'll put a link in the chat window that you can click on. It's a clinical trial, but they send it to you through the mail. It's called the Promise Study. And it's a good solid test, and it'll tell you if you've got any germline, any inherited mutations. Do you have any cancer in your family, Luther?
Yes. Lung cancer.
Okay. Anything else other than the lung cancer?
No, not that I'm aware of.
Okay. Let me just put this promise link in the
I
chat.
actually saw that link, that promised link on AnCan website.
Okay, so you have that link, or would you like me to put it in again for you?
I have it.
Okay. So, all right. Now that takes us through to about 2020, and tell us what happened after that.
And PSA came back again. Started out in very low point in the tenths, 0.4, 0.5, 0.6. But even at that rate, it was doubling within 6 months.
What year was this, Luther?
It would have been in 2021,
Okay.
late 21.
Okay. So it came to about 0.4 to 0.6, and what doctor were you seeing at this point?
This was Dr. John Stone at Moffitt.
Yeah, I think I know of him. Okay. And how did he treat it?
He wanted to give it another year, and I wasn't satisfied with that, so I asked that we look at it sooner. We settled on 6 months, and 6 months it had doubled again.
Okay.
So then I had a PSMA, and it showed that it had metastasized.
To where?
Prostate bone in uh, right scapula, lower spine, and in the rib cage.
Okay, so it had metastasized to the scapula, the lower spine, and the rib cage. And how did Dr. Stone treat that?
He handed it off to another oncologist at Moffitt, Dr. June.
Yeah, I do know who that is. He's definitely a GU medical oncologist. And what did Dr. June do?
He wanted me to go back on hormone therapy, and I went on Trelstar.
Just on Trelstar, nothing else?
Well, that was an issue I had too. I thought I should have been on first and second generation, but he did not believe that was the case. So just on Trelstar, I started that August of 2023.
I mean, I think we all would find that in this group a little strange because if you had bone mets and in 3 or 4 places, why he didn't put you on a doublet back in August of 2023? So you went on the Trelstar. Did it depress your? Did it hopefully it pushed your PSA down to 0.
Yeah, it went undetectable 3 months later.
Yeah, and then what happened?
I continued on Trelstar until October of 2024. And at that point, I discussed with him that the quality of life was not good with lack of energy and fatigue. So he agreed that I could go on a hormone deprivation holiday. And that's where I'm at to date.
Okay, so at 8/23, sorry, What date was it he said you could go on the holiday?
October 24th, October 1924, 2024.
Okay. Just a couple of things for clarification. Was Dr. Johnston the same radiation oncologist who did the treatment for you back in 2019?
There was no radiation back in 2019.
Well, you said that you had radiation therapy, 36 treatments to the prostate bed.
Yes, but that would have been in 19. You know, I got to apologize to this group. I mean, if I had known you were these type of questions, I would have had my medical.
Well, Luther, you were here last time and you heard us ask the same questions.
I didn't hear an interview last time.
Well,
Anyhow,
we did 3 of them, and because we didn't have time to get to you, but no worries. So, who did that original radiation? Was it Dr. Johnston?
the radiation that was done in 2019 was Dr. Johnstone.
Okay, so
Now
I'm
the
getting
only radiation that I had.
okay. So now 1024, you went on a holiday, and you have never had abiraterone or enzalutamide or anything like that, right? Or darolutamide?
Correct.
Okay. So, how long have you been on this holiday now? Just a couple of months?
Yes.
And how are you doing? How is your PSA still undetectable?
It was at that time. I've not had it checked since then.
Okay, well, one thing that we would say to you is you need to check it regularly if you're on a holiday. So,
Okay.
it's not expensive. It's covered by your Medicare. If it were me, I know some of the guys go longer, but when you're on the holiday, I'd like to see every month, every 6 weeks. If it were me getting it, that's what I would be doing. I wouldn't just be sitting and waiting because we don't know what's happening.
Let me just share with you. I'm not sitting and waiting. I'm actually looking for another oncologist for a second opinion.
Okay, so probably we would, as you well know, you can't use anybody else at Moffitt. You're aware of that, right?
Yeah, I've found an oncologist down in Sarasota.
That's who I'm going to send you to, Dr. Guancial, right?
Yes.
That's exactly who we'd send you to, is Dr. Guancial. She's very, very sweet, very compassionate, very well trained. And if you can get in to see her, because it's not always that easy, tell her Len Sierra sent you.
Yeah, she was recommended me by David Morse with the Prostate Cancer Initiative group.
Yeah, he took over from me at the Sarasota Us Two group.
Okay.
Okay, and that's how he knows about Dr. Guancial from Len, because Len sees Dr. Guancial when he's in Florida.
Okay.
And he sees Dr. O when he's in the Northeast in New York, and Dr. Guancial trained under Dr. O.
Okay, that's good to know.
Okay, so what else can we do for you?
I think nothing right now. I mean, I'm new to the group and I'm interested in understanding the journey that others have taken and what their present status is. So I guess I'll just become a listening member at this point.
That's great. And don't hesitate to ask a question. We have, I don't know how many people today who are here right now are on a holiday or on a drug holiday. Jim Marshall, Len, Dr. John, there's somebody, wait a minute. Oh, David Muslin. Okay.
George.
Ron Rogers. We've got quite a few. So, including at least one octogenarian that I know. Oh, and we've also got Gary P, and we've got Jeff Marchi. So we have many people. So if you want to ask them any questions, now's the opportunity.
I don't have any at this point. Like I said, once I get contact and get all my records to Dr. Quancio, I'll know better.
Okay. Jeff Marchi, your hand is still up. Is that because you'd like to say something?
Yeah, I would. I just don't know if you've emphasized to Luther that with the Gleason 9, his cancer is extremely aggressive, and he should be getting monthly blood tests, PSA tests, because after cutting off your hormone therapy, it could come back within a matter of just a few months and start rising quickly. You just be careful about that. You don't want metastasis to start to appear in your body because you weren't getting regular PSA tests.
Jeff,
That's
I
what.
appreciate that, and I found that one of my reasons for being dissatisfied is there's very little collaboration with the various doctors, and there's very little communication with regard to the possibilities. I have to go primed with questions to generate that type of information.
Okay.
Well, that's the reason why, my first response to you was you want to get a test every 4 weeks to 6 weeks. Exactly what Jeff just said to you. So
Yeah.
I think that's sort of important. All right. Well, I don't know that there's a lot else now, and I'd like to move on to Bob. And I also see. Let me just see here. There's somebody who came in late, and I just want to. Yes, Larry Schuler. Larry, have you been with us before? You're muted, Mr. Schuler.
Yes,
Unmute.
thanks. A couple of times I've been listening in, and I always have trouble logging in.
Okay. Well, I don't have you. I don't have you in my notes. SCHULLER.
Yes.
Oh, wait a minute. No. Right, I do. I vaguely remember you because I see you're in Alaska. Well, let me say if we've got time at the end, we'll come back to you. But we have a rule that
Right. Newcomers have a presentation, but we want to log in early so you get us on a schedule.
yes. So if we don't get you this week, Ben
That's okay.
Nathanson will get you next week. Okay.
My presentation really isn't ready yet.
Okay. Well, that's good. And I do remember you did come in and you didn't want time. Now I remember. You said you didn't want time last time.
Right.
I've got a few notes on Larry, Rick. I'll send them to you, but they're not complete
Okay.
by any means.
But while I've
Oh,
got the floor, I'm having PSA testing every week.
Wow.
every week. Okay. Well,
I'm a clinical trial of one. I had a PSA doubling rate of 2 months before I started ADT.
okay. I've got to stop you right now. We
Yes.
don't have
Okay.
the time. We can't get into your story right now.
But
Come
I thought
on
that was
time, and we'll definitely listen to you, and we'll give you time, and we may have some time later on. I've got to go to our other new gent, who
Rick,
is
can I just insert one thing here? I'm just looking at Dr. Jones' response in response to your question of why he didn't want to put me on the second generation. And he says here that given that his cancer became metastatic with low PSA values, adding a second generation new hormonal agents like abiraterone would increase the risk of neuroendoctrin differentiation, particularly in the setting of undetectable PSA.
Yeah, well, I would argue with him that given you had low PSA, you may already have neuroendocrine cancer, and we don't know that
Okay.
because low PSA is a difficult cancer to manage. I'm not a doc, but in my view, you don't treat somebody with metastatic cancer and a low PSA by not giving them a second generation anti-androgen. What you would do is see how they responded, and if they didn't respond to it, then you would do something else. But to ignore it, no.
I've heard that from many people, and that's why I'm looking for another second opinion.
Okay. All right, we're going to go to Bob Schwartz. Hello, Mr.
Good evening.
Schwartz.
Good evening, gentlemen. Let me identify myself. My name is Bob Schwartz, and I want to thank each and every one of you here, especially those that have been here some time. I wish I would have known about you sooner. My wife was actually the individual that found you for me. About a week before Hurricane Helen struck, I was doing some do-it-yourself plumbing in the kitchen where I was
Hold on a minute, Bob. Hold on. Let me ask you the questions because we'll get through it quicker. But you can tell me, how did you find us?
My wife found you.
How did your wife find us?
Doing research to try and find out what my problem was.
Okay. And are you signed up?
Yes.
Did you get a reminder for this meeting?
Yes, I just signed in today.
Okay. So we have you on our database, and you'll get a reminder have you registered on out for reminders?
I believe so.
Okay. Well, for good order's sake, and if your wife is sitting there, we love having care partners in the group. She can join in with us. She doesn't have to stay out the picture.
She doesn't like being on camera.
She doesn't like being on camera. Okay, well, she can pipe up. Please put your email address in the chat window. If you don't want it to go to everybody, you can just send it to me or the organizers, and we'll make sure that you are in the database. How old are you, Bob?
69, and yeah, I did sign in with my email. It said, "Did I want put my email in?" And I did do that.
Okay, well, we'll no doubt we'll find you. If we don't, you know where we are. Except next week we're on a Tuesday and we're at 6 p.m. Eastern, and then the week after that we're back on a Monday. So we go Mondays and Tuesdays here. Where do you live?
Venice, Florida.
Oh, Leonardo, you got a buddy. Introduce yourself, Len.
I can't
You're
hear
muted. You're muted. You're muted.
Yeah, Bob, Len Sierra, I've been in Venice since 2019. And before that, I was in Sarasota for many years.
I've been down here in Florida since 2005.
I got you beat by 3 years. Well, I'm not there. I'm not there full time though. I'm only half time.
Okay. Now, if you ever want to come by, I'd like to hook up with you, have a cup of coffee or
Yeah,
something.
absolutely. Well, let's do that.
Okay, you guys exchange. Len, you can put your email address in the chat window, and then you guys can go from there. Len right now is up north because he's still waiting for a contractor to come by. Isn't that true?
Well, supposedly they finished up this past Saturday.
Okay, all right.
Yeah.
Okay, Bob, what year were you first diagnosed?
Just this past week.
Okay, you were just diagnosed. Okay, and what's your Gleason score and your PSA level?
Well, that's what I like to explain. I don't have a Gleason score because when I first had this problem, I just thought I'd injured my back. And I went to the orthopedic doctor, surgeon, and he referred me to a oncologist, and I had no idea what a GU was I needed or anything like that. So I went there just to find out what it was. Unfortunately, I didn't really get along with the oncologist. They did a lot of tests. They did x-rays They did MRIs, they did CTs, they did a biopsy, and they did a PSMA scan. And when I asked them what type of cancer I had, she said she didn't know. And I said, well, what do you need more? And she said the biopsy didn't show anything on my back. She said she now wanted to do a biopsy in my back in the bone now. And I said, shouldn't I be seeing a urologist? I'd done some research, and my wife did some research and asked her some questions. And she was very put off by my wife asking questions, and she was put off by me.
I hate to ask, but this wasn't Dr. Guanciale, was it?
No, as a matter of fact, it's in Venice itself. It's a Florida cancer research specialist.
Okay, well, the first thing you need to do tomorrow morning is get your butt over to Sarasota and get an appointment with Dr. Guanciale.
Well, let me tell you what I've had since then, since I was unhappy. And
Yes.
this is before my wife found you guys. I searched and I found the 3 hospitals in Florida that have NCI status, and they were Mayo Clinic, Moffitt, and University of Miami Sylvester Comprehensive. And I went up to Moffitt and I met Dr. Zhang. Okay, and I explained to him the situation, and he looked at the information I had from my CT scans and all that, and he said, I can tell you right now, you got prostate cancer, and it's metastasized throughout your body. And he said, you should be put on something right now. I said, would you mind being put on it today? And I said, no. And that's when he ordered 2 pill prescriptions for me, and he gave me 2 shots. Let me see what it is here.
Now, when was this? This was yesterday? Because you said you were just...
No, it was Monday before Thanksgiving.
Monday before Thanksgiving.
Right.
Okay, so...
We've known he has cancer since the CT scan, because they told us that it was probably prostate. His PSM was 325.740. And
Okay,
then
so your PSA was 325?
Right.
And the doctor gave you a PSMA scan, but she said she didn't know whether she didn't know what the cancer was.
She wrote down prostate with a question mark.
Yeah, well,
And then they did
we won't be recommending her, right, Len?
What, Rick?
I said we won't be recommending that doctor in Venice, will we?
No, absolutely not.
No, and then she ordered a biopsy, but they biopsied a lymph node in his back.
Okay,
And
so
that came back as necrotic, and there was no information at all.
So I just want to sort of cut to the chase here. The PSMA scan that you had, where does it show metastasis?
It says, I don't understand it. The impression, it says tracer avid adenopathy in the left lower neck, mediastinum, the abdomen, the pelvis, all favoring nodule metastatic disease. And then it says index lesions as above, and then up there it lists a whole bunch of stuff. And then it says the significant bony fascie seen consistent with OSS-EOUS metastatic involvement with index lesions.
So here's the and I'm assuming Dr. Yun gave you abiraterone and Orgovyx. Is that right?
No, he gave me Adderall, and he gave me
He gave him that, and he gave prednisone, and he gave him 2 shots of Firmagon.
Okay, so he gave you Firmagon. He gave you Firmagon, which is the same as Orgovyx, but it's an injection rather than a pill. And he gave you Abi plus prednisone. Now, here's the problem. If you have, and I don't know, I can't say, do you have more than 4 or 5 different places where you have prostate cancer in your body?
I would assume so.
By our interpretation of the reading, yes.
Yes. So,
well, the skeletal says there are innumerable.
Okay, so
avid bony
innumerable is enough. The standard of care is more than what you got. Standard of care is actually chemotherapy. I hate to tell you, but it is chemotherapy, and we do know that it works the best.
Would it be in conjunction with what I'm taking also?
Yes, in conjunction. It's called triplet therapy because it's the firmagon, the abiraterone, and the chemo. The
Okay, that's what
prednisone
I wanted
goes.
to ask you. An individual that I was looking at that my wife said she heard on your site, and it's a little bit further of a drive, but I wouldn't mind doing it if I get a good doctor, was at the Sylvester Comprehensive Cancer
I
Center.
don't. I'm going to let Len address this. I don't think you have to go that far. I think Dr. Guanciale is going to be just as good for you at Sarasota. Dr. Belusic at Sylvester is great, and we're going to be talking about him soon, and he's really good. But I got to tell you, if it were me, I'd probably go to Dr. Guanciale just as soon as I go to Belusic. I don't think there's, I think it's 6 of one and a half dozen of the other. You might even like her better.
Well,
And
one thing they
she's
told
in
me was
Sarasota.
they said I might not be able to switch doctors because they were at the same Florida Cancer Research Organization.
No, but yeah, she's at Florida Oncology, isn't she, Len?
She is a part of Florida Cancer Specialist, which
Yeah, that's
sounds
all.
like what he's
Yeah.
using now. However, because it's a different location, I don't know. Possibly they might let him see her.
No, we had that with Russ Hoover, and she,
Oh yeah.
they,
Yeah,
yeah, they
you're
couldn't
not
go.
always the nicest people. Certain ones.
Yeah, it was hard to get my records from them. It was like pulling teeth.
Yeah, so it's possible. The doctor you didn't like is at Florida Cancer Specialists,
Yes, on the island.
right, and Dr. Guanciale is at Florida Cancer Specialists, correct?
Correct.
Correct.
All right. What I would do is call up the doctor you didn't like and ask her, will she please refer you to Dr. Elizabeth Guanciale in Sarasota, who specializes in prostate cancer. If she says no,
Yeah.
I would probably then say, yeah, okay, drive over to see Dr. Belusic. But there's a very good chance that she may say she's willing to do that because she's just not a specialist.
She's not a GU, I know that.
She's not a GU specialist, and she doesn't really, from what you're telling me, she doesn't really know the first thing about prostate cancer, because with 325 in a PSMA scan, and she's still putzing around as to whether you've got prostate cancer or not. So I would try calling her and saying, would you be willing to send me? You're going to have to be nice because they're very difficult at prostate cancer specialists. But if she'll do it, then I'm sure that we can convince Dr. Guanciale to take you if she's referred by somebody else in her practice. If you walk in the door, she's going to say no.
Okay. But if not, there's the other option, which would be going over to the University of Miami.
We've never had much luck with the GU medical oncologists at Moffitt. We just haven't. I mean, I don't understand why this guy didn't even discuss triplet therapy with you.
No,
But let me turn it over to some Len. I mean, why don't you start, and then some of the other guys can come in. Oh, let me ask you quickly: has anybody done any gene testing on you?
No.
Okay, so the PROMISE study, which I will put in the chat window, is very easy to access. And I would suggest that you send off for that right away, because you don't need to get your doctor's permission. That will tell you if you have anything inherited. Do you have any cancer in your family?
It's unknown.
Okay. So I definitely do the PROMISE study. And then it's standard of care that you that you get what's called a somatic test to see what mutations you're making, and it's important. Now, it'll probably still work, but you need to do it quickly before the these medicines take too much effect, but you can probably get it through your blood, or you can get it through. Did they do that biopsy? Hopefully they didn't biopsy your spine, did they?
No, they were going to. They did the
Yeah.
lymph node, but they wanted to. They were ordering one
Yeah.
out of these.
Well, the lymph node maybe they can get away with, but biopsying the spine is a dangerous thing to do in a man with metastatic prostate cancer. And
Yeah, she wanted to do it to the bone. They did do a Guardian 360 test, though.
oh, they did. Okay,
Yeah.
well, so that's really what and do you have the results of that yet?
Yes.
Yeah.
And what? So that's the somatic test. And what mutations does that show?
Hold on one second. We're getting that, though.
Okay, well,
And,
I'm glad they did that test, although we would probably not have recommended Guardant, but it's better than nothing.
There's detected biomarkers TP53, H179D.
did you hear that?
I heard TP53. What's the next one?
H179D.
Yeah.
What does that mean?
I think H179B is an androgen receptor mutation, isn't it, Len?
I think so. Yes.
Yeah, TP53 we're very familiar with. It doesn't indicate anything. A lot of the guys have it in this group, and it's very common. It's common in about 30% of men with advanced prostate cancer.
But it's not targetable. There's no drug to target that mutation.
Okay.
They said the prognosis was prostate endocarcinoma.
Yep.
Adenocarcinoma.
Adenocarcinoma. So, I mean, it all sounds great. If TP53 and the androgen receptor mutation were the only two that showed up, we know that. There's not much. It doesn't change your treatment path much. But the next time they do it, which might be in a few months, I wouldn't go back to Guardant to get it done. I would go. We'll help you when that time comes. Len, why don't you want to sort of talk a little bit about triplet and doublet and triplet?
Yeah. So as Rick suggested, for someone in your stage of prostate cancer, the current standard of care is triple therapy, which is chemotherapy. The name is docetaxel. That's the name of the drug they'll give you. And an ADT drug like Lupron. And, or what did you say you were taking? Firmagon?
Yeah.
Yes.
Yep. So you got that. And then an androgen receptor blocker. So what was the other drug you're taking?
Abby.
Okay. Yeah. So what they would do is just add docetaxel chemotherapy to that doublet that you're on right now. And the only thing I would suggest to you, maybe your best chance of getting to see Dr. Guanciale is if you tell your existing doctor that you need a GU oncologist, GU specialist. And since you say she is not one, that should be sufficient reason, I think, for you to transfer since you have advanced prostate cancer.
Okay, I'll give it a try.
Yeah.
But it's still like that because when I went up to Moffitt, they just put me on. Yeah, I was happy that he at least started me on something because with all the pain I was in it, because my back was like killing me, and he said that the drugs that they were giving me would help my back pain get better. So I don't know if that's true or not either.
Well, it should. Yeah.
Well, he has a fracture in his back too because he fractured his back. One of those.
So the other thing that they should be talking to you about is a bone strengthener. And that's something that June should have spoken to you about at Moffitt, but if not, Dr. Guanciale definitely will, and Dr. Blusic will. So
I had mentioned that to the doctor I was seeing here, the cancer doctor, and she said that was old school. They don't do that anymore.
Well, let's see how old school it is. How many guys in this room are getting bone strengtheners? It
It's
ain't.
actually standard of care.
It's standard of care. It ain't no. It ain't old school. Not only is it not old school, um, but it's actually prescribed.
Okay. It's something I would like to have done since my back is sore. And right now I'm limited to just walking. I can't work out like I used to.
Okay, well, you've got to be careful because you've got metastases in your back. You've got to keep doing the workouts, probably in under supervision. We'd recommend you work with somebody who has a cancer certification with the American College of Sports Medicine or somebody like that. Or I don't know if there's a Y close to you that participates in the Live Strong program, but you should be supervised.
Okay. And see, I was looking to try and find somebody that knew everybody to do it the right way. Because once I heard about the GU and all that, that's why I went up to Moffitt and I found Zhang. And he's the only GU up there that I know of. And then he wants to send me to see a urologist.
Yeah, they wanted to do another biopsy.
Yeah, they want to look at it to see about possibly doing a biopsy on the prostate.
It's prostate, by the way. There's no R in there, no second R.
Okay.
Prostate. So, I don't know why they would need. I mean, it's pretty clear that you're an adenocarcinoma. It doesn't sound like you are. It doesn't sound like you're at risk for morphing yet. There's some conversation going in the chat between the moderators about TP53 and carboplatin. I would say no, they don't give carboplatin for TP53. They save that if for situations where they suspect there might be morphing or certain other types of certain other mutations occasionally. But I've never seen them give a platinum just because you have TP53 or P10 or RB1 for that matter. Now maybe if you had all three, they might. It's possible.
Now let me ask you this doctor in Sarasota, would she be able to give me the injections that I need and things like that?
Yeah.
Okay. And then as far as the back, she would refer me to somebody, I would imagine?
No. I think what's going to happen with the back is that as the treatment takes effect, you can expect the back pain to wane.
Okay.
There's no, I shouldn't say there's no. There's a couple of things. One is you can definitely ask your doctors for a palliative care doc. I definitely would suggest that. Palliative care is symptom management. It's not end of life, even though it often gets confused. And you can work with the palliative care docs on how to manage the pain in your back.
Okay.
Now, I'm assuming that Florida Cancer has, Moffitt definitely would have, Sylvester definitely has. So, we'll get a palliative care doc on your team as quickly as we can. Also, you'll need a palliative care doc if you start chemo.
Okay.
To handle some of the side effects. I'm going to take 5 more minutes and then we've got to get on to the questions. So we've got a couple of hands up. I'm going to start with Jim Marshall.
Excuse me, Bob, are you a veteran?
Yes, I am.
Oh, you should contact me. I will put my email address in the chat window. Do you know how to see the chat?
It's up in the right hand, the little bubbles.
My wife says it's supposed to be up on the right-hand side, the little bubbles.
The two boxes that are together. How about they click on it?
Click on this.
Okay, have you clicked on it?
All
And
right,
you'll
right
see
there.
a
All
bunch
right,
of
I got
stuff.
it now. Yes.
Okay, well, I will be contacting you. You can be entitled to a lot of VA benefits. Okay?
Okay. Right now, I appreciate anything help, any kind of help you can
Okay.
provide.
No problem at
So
all.
tomorrow night at the same time, but in our other room, the Schmear room, Captain Jim will be conducting a meeting for vets. That meeting is not prostate cancer specific. It is about managing your health care and your benefits. And we definitely recommend you join that meeting. Captain Jim will forward,
Yeah.
if you put your, for good order's sake, put your email in the chat window. Jim will send you the reminder for that meeting for tomorrow night. And he will also put the link up for the room. It's not in this room, it's in our other room.
Yes,
Okay?
I will do that.
And maybe you can exchange emails with right now with Captain Jim, and then we'll be sure to get you in there tomorrow night and start getting you straightened off. I'm going to put Captain Jim's email.
Already putting it in, Rick. I will do it. You're busy.
Okay, well, I done it now. So
Well, I
so
got two of them, yeah.
it's right there, and we'll get you sorted out.
Okay.
And we've got still a couple more people with questions. Jeff Marchi.
Yeah, I just wanted to mention the two things that you may notice right away, and that is hot flashes and fatigue from the drugs you're taking. If you have hot flashes, come back here next week and we can give you a lot of ideas on what to do to control them. You may not have felt them yet, but you probably will. As for fatigue, you're going to almost definitely have some fatigue from the drugs you're taking. Exercise helps a lot. I know you said all you could do was walk. Hopefully soon you'll be able to do more, but that can offset the exercise, the fatigue. And just be aware you can come back here and we can help you more with that if it's a real problem.
Okay, thank you. I appreciate it.
And Larry Schuler.
It's not you're a veteran. Are you service connected for your cancer?
No.
Have you served in any of the areas covered
Okay,
by the
I'm going to cut you,
Hey,
Larry. I'm going to cut you off because we don't have time. Tomorrow
Just,
night is the
just
meeting for that.
okay.
Okay, tomorrow night's the meeting. Captain Jim will go through all of that with him. We'll find out if he is service. He may think he's not service connected, but we may find out that he is service connected. That happens often.
absolutely.
So
Absolutely.
I don't want to get into the veteran stuff for this meeting, but for tomorrow night, and feel free to. That's where I've seen you, Larry, in the veterans meeting. Now I realize. So come on into the veterans. You too tomorrow night, Larry, and we'll get you sorted out with your vet. We'll get you registered. If you're not registered, I won't even ask any more questions. Anything else for Bob Schwartz right now before we move on? Okay. We're moving along. And where's my list? Where's my list of is this it? I hope so. Yes. All right, Mark Valens. Go ahead.
Well, I've been down at UCSF for 12 days. Um, I'm getting radiation daily for all the mets up and down my spine and on my skull. and I've started chemo. You can notice, and the I got good care down here. The one thing I was going to bring up, which Dr. Agarwal, who's my new GU med-onc that Rick steered me towards, he stopped my darolutamide, which took me a real long time to get it approved to get that. And I asked him why, and he said there's no clear and established role to continue ARPI, androgen receptor pathway inhibitor, while on docetaxel chemotherapy, especially given clear radiographic and symptomatic progression. So in other words, it doesn't work. It's not working for me. It's not helping at all. So he's having me discontinue it. So, but I'm still on Lupron. I'm getting radiation. I'm getting the chemo, and that's all I got right now.
This is going to be confusing for somebody like Bob Schwartz, because we're telling Bob Schwartz he needs a second-line anti-androgen, whether it's Abi or docetaxel, and he needs ADT and he needs chemo. I think the reason why is because in your situation, Mark, you've been on these drugs for a long time and it's returned. And what we're seeing now is a progression. Plus, there's a strong suspicion that your cancer may not be sensitive to hormone therapy any longer. We don't know. Now, we know it's not totally true because there was so much that showed up on the PSMA scan. But I think that Dr. Rahul is sort of rolling the dice and saying, I think the docetaxel can take care of this right now. We're not going to get enough extra out of the darolutamide to make it worthwhile. That's my guess. And your PSA is low. What's your PSA at right now?
Oh, I've never had PSA. So.
You never had PSA. There you go.
Even with a Gleason 9, I never had PSA.
I know. I mean, so this is one of these situations where, you know, you have a Gleason 9 and you have a low PSA, all the more reason why we should be giving you more drugs, Luther. This is one of these examples. Anybody want to comment on removing the darolutamide? Dr. John.
Well, the Lupron will continue, right?
For now.
The trouble is, well, he went through hell to get on this darolutamide. So is it adding anything to the treatment? You have high risk by Gleason score, and you can't track your cancer by PSA. So I suppose you could go off darolutamide, but how are you going to track your cancer to find out if it's active or not? You'd have to have PSMA scans, right?
Well, I'm getting the chemo, and he wants every third cycle, so every they're 3-week cycles, so every 9 weeks we'll do a PSMA again, and when we get to 6 cycles, if it seems to be working, we're going to do another 3 cycles.
Okay.
And that's as far as I've got with him.
Okay, and don't forget that next time you do a PSMA, you want to do an FDG PET too.
Yes, we're going to do that.
Because Dr. Rahul is looking for any lesions that may not express PSMA, and if we find any, he wants to biopsy them.
Yeah.
Okay. Well, I don't want to shortchange you, but we got a bunch of people, and I don't know what else. Anything else that anybody would like to bring up? Yes, Larry Schuler.
Uh, circulating tumor testing, would that be of any value?
Not really right now, because we know that there's a heavy burden. The PSMA is right there. We have discussed, but where did we leave it with getting a another somatic test, Mark?
It's underway.
It's underway, so we're getting another somatic test right now. And the CTC is only going to tell us about the existence of cancer. If we analyze that CTC, which is exactly what we're doing right now, we'll find out what the DNA patterns are in there. Dennis Correa.
Yeah, just as a side on this, I remember reading about darolutamide and that it did show some good results in the trial with the chemo in conjunction with
Yeah,
darolutamide.
yeah, but that again is early stage, Dennis. That's the triplet. You're confusing that with triplet, which is what I said right at the beginning. So in other words, if you were just diagnosed and you had metastatic cancer, it would be an option to give you ADT plus chemo plus darolutamide.
Right.
That is not the situation that Mark's in. Mark's got long returning cancer, and we know there's plenty of, some of it expresses PSMA, some of it may not, we're not sure. So this is not that approval, and Len will correct me, I think was even for de novo metastatic, wasn't it, Len? Wasn't
Oh boy.
darolutamide?
Yeah, I don't really remember, Rick.
Yeah, I think it was de novo metastatic, which is not Mark's situation. So a different ball game. This is where there's long progression, and it's a complicated situation because Mark has a cancer that's been described as a unicorn zebra.
It doesn't follow any of the rules.
Okay.
Thanks, guys.
I'm gonna keep moving along. Dr. Jack, I've got to ask you to make this to make it a quickie,
as brief as
not a
possible.
long history. Get to the point about what you want to ask the guys, because it's a
Okay,
good
what I want
question.
to ask you guys today is I had a consultation with my my original medical oncologist, whose name I won't mention right now, and he, after he heard my history, which I've been having difficulties, the sarcopenia, at least from my point of view as a physician, has, I believe, generalized to all of my muscles, including my cardiac muscle, including my smooth muscle in my gut, and it affects my gastric motility to the point where the other night I was up all night unable to belch. I felt terrible. I felt I was going to explode because I use a CPAP at night because of my atrial fib. So in addition to that, having a history of atrial fib, my left atrium, since I've been on this medication, has dilated from 40 up to 59 within a year and a half since I've been on this medication. I'm going to have a transesophageal echo to get a good determination whether or not I'm a candidate for a clip, which is on the mitral valve, and that kind of scares me. And I think it's all kind of related to this medication I'm on. I can't open and close my hands. I've never been like this in my life because I work out every day, so I won't get massive sarcopenia to the point where there's such irritation of my tendons, I can't close. Third thing, and my absolute neutrophils are so low, lower than they've ever been, and I start getting infections and I have to take antibiotics. So my consultant in New York, who, I've been with Sloan Kettering for 22 years since I had my surgery, He said to me, "Time for you to take a holiday." I was shocked. I mean, it's 18 months in less than 2 weeks. I was going to go for 24, be heroic about it. He said, "Look, you're 85. All right, let's see if we can give you a quality of life. Let's not worry, about if it comes back, we'll do SBRT again, like I've had, and we'll put you on some doublet therapy again. So, but your PSA is 0. Your tumor burden is very low. My FDG that I had done 2 weeks ago showed no metastases anywhere and no reoccurrence. And he said to me, "You're looking good. Time for a holiday. I wouldn't go for the 24 right now because it may be too risky for you. And get yourself checked out all around in the other areas you're concerned about, maybe with the testosterone coming back, and we'll see what happens with your PSA, and you'll follow it closely. And if you have to get another scan, you'll get another scan." And he's insisted. I'm confused. He said, "You'll get another FDG scan." I said, "Why not PSMA?" He never answered it. I don't know. Maybe you guys understand that. So my question to all you guys is, so many of you have been on holidays. How did you handle it? Because I'm confused a little right now. I like the idea, but I don't like the idea. I don't like the idea because I've been with the security of knowing this has taken me from no metastasis, from metastasis in my lung area and my bones to no observable metastasis. My PSA had went up to 2.1, down to 0. And it's been like that for a long time, 18 months. And I've got this security blanket, and I'm letting go of it, and I don't know exactly when to do it.
So Jack, I gotta interrupt you. Let's get some feedback from the guys. Okay.
Thank you. All right.
So who wants to talk to Jack about dealing with going on a holiday? This is sort of like we were talking with Luther Cowden about before. Anybody want to speak up? I think the first and most important thing to say is what we told Luther, is that make sure you get your PSA checks every 4 to 6 weeks. Dennis, you've been on a few holidays in your time.
Yeah, I think the first one is it's getting started with it psychologically. You think, all of these drugs you were taking got your PSA down to non-detect, and why would you want to stop if you're still enduring the side effects of it? But you really need to take that break for a while. The other information out there is tending to look like, this can cause morphing too, when you don't give your body a chance to respond and get back. It is somewhat psychological, but I've been doing it now almost 9 years. Not as long as you, but still have a prostate and Gleason 9 and all that good stuff. And, I have bone metastasis in my spine, but every time I get down to less than detected, I'm ready to take the holiday again. It's just my.
So Len's laptop crashed. So because he's always my go-to guy on holidays, but my backup is Dr. John.
Well, I don't know how to advise that. I'm sure that he picked up a lot of distress from being on these meds, and just thought, this guy's suffering too much from these meds. Let's give him a break. Sometimes it's a judgment call whether you are more conservative or more aggressive in treatment. And he can just see that this is messing up your quality of life, and I bet that influenced the decision. But you did bring up something that never occurred to me before. We have 3 different kinds of muscles in our bodies. We have the skeletal muscle, like our biceps and our quads, that make bones move, and we have cardiac muscle that makes our heart beat, and we have smooth muscle all around different automatic places in our body, like our intestines and lots of different other places. And every time we talk about muscles shrinking up from being on ADT, it's implied that we're always talking about skeletal muscle. I have no idea whether smooth muscle and cardiac muscle are also dependent on testosterone for their maintenance or not. I
Why wouldn't they be?
Why wouldn't they be? But they are different kinds of muscles, aren't they?
Yeah.
They're physiologically different. I am kind of suddenly fascinated with that question.
Yeah. Look at
Hold on a minute. I'm gonna go to our resident internist for a consult.
Okay.
sleep.
Dr. Jeff,
Wake
what
up,
do
Jeff.
you think? Dr. Jeff.
I'm sleeping.
Oh,
No, I'm
he's
not sleeping.
sleeping.
Uh,
Oh
not
no.
sleeping.
Oh my gosh. No, he
I'm
wasn't.
Jack, I'm gonna sue you for defamation. I'm not sleeping. I'm listening.
I'm resting my eyes, my mother used to say. Oh,
No.
yeah. Okay,
So the
Mom.
bottom line is, I can't imagine that cardiac muscle is not affected by the lack of testosterone.
I agree.
Smooth muscle, that I'm not sure of, but I would tend to think that lack of testosterone causes some atonic reactions in the GI tract also.
For sure.
Talking to a lot of people who are on ADT, a lot of people complain of constipation.
Okay. So, and you think that's also like a similar
Yeah.
type of muscle that can be affected by the.
The whole GI tract gets kind of slowed down. The motility is slowed down. I'm telling you, with this belching thing the other night, I had some. That's why I'm drinking all of this bubbly water, so I can get it out, because I in the middle of the night I was up all night.
Okay.
I just couldn't. Well, you know.
All right. Dr. Alfredo, is there anything you'd like to add to this discussion?
Yeah, I was just thinking about it. I remember looking at a study that was concerned with vascular smooth muscle, and there was a clear effect of sex hormones. So I'm in the camp that says I can't imagine that all three types are not affected by testosterone deprivation. I think all three types are. It might be a matter of degree, but I'd be stunned if there's a difference.
Dr. Muslin, you want to chime in as well?
I'm no doctor, and I think I know Jack pretty well. And Jack, if you're that miserable and you're 85 years old, God bless you, you've done for 18 months and you've gotten through it, take a holiday. That's
For
what I
sure.
would do if I were in your shoes. I mean, you'll talk, when it's my turn, I'm going to be talking about my holiday too, but take a holiday. And I mean, you go back, let your body recover, go start working out again. And you've been at it for 18 months. And if you're checking your PSA every month, you'll see if it starts to tick up. You can always go back on it.
I'm sure Belusic will go along with it. He's very supportive.
And I want to agree with that. An example I often use is whichever way you go, you're going to make a difference in your lifespan of approximately 11 minutes. So you might as well have quality of life for a little while.
That makes a lot of sense.
Okay, look, we gotta keep moving here. I'm tempted
Thank you, guys.
I'm tempted to just come back to Jim and Dr. Jeff and skip over to David Muslin because it's about holidays. So let's stick on the holiday issue and go to David Muslin.
Okay, let me give you some brief history so everybody has context. Had a radical prostatectomy in June of 17. Had radiation in that same year in December without ADT. Did not have AnCan at that time and had no idea what I was doing, and I was just afraid of ADT. By February of 2020, I got a little smarter, got back on got on Lupron, and the doublet therapy with Enza and Abby. I did that for 19 months, and then after 19 months, I went on solo darolutamide, which I stopped in September of 23. I've been non-detectable all the way up through April of 24 of this year. And it started ticking up to 0.21 in May, and then 0.25 in June, and then 0.75 in September. And those last in September and in June, I did scans and they came up clean. I was at Dr. Schmulowitz on Friday, did another scan, came up clean, and PSA dropped to 0.64. I was really, because my doubling time was really every month. So I was really expecting to walk in there and have it to be like 2.25, which is 0.75 times 3. And it dropped. I was shocked. And bottom line is, Shmulowitz says, let's scan again in 3 months, and we'll see what happens. Go enjoy your life. And so that's my check-in. And my question to the group is, I was shocked that my PSA is starting to drop. Have we ever seen that before? And I just want to comment to Jack. Jack, Shmulowitz says, do your scan every 3 months. If I was worried about not getting back on ADT, he says, David, we're checking you every 3 months, and if something's going on, we'll catch it. Go enjoy your life. And you know that you can apply that to yourself, Jack. But now we'll make it back to me. So sorry, I hope I didn't go do that too quickly. So have we ever seen that before?
So it's the scanning that will determine whether or not you go back on darolutamide or doublet therapy, not the PSA?
So I asked that question. I says, is there a certain number that you go back on ADT? And he said, there's an old study, but that doesn't really apply anymore. He says it's a personal decision if you want to treat the PSA number, or you want to wait to find the metastases. He says that's a personal decision of quality of life.
Right. Did Len get back on or not? I think not. Because Len's the expert on this one, David. I mean, you know, he goes off on these holidays and he doesn't pay any attention to his ADT, to his PSA, and he does the scans and he pushes the envelope and he gets up to about 2+, 2.1, 2.2, and then he goes back on again. And he goes on for a little while and then he comes back off again. And I absolutely agree with Dr. Shmulowitz that what we should really be looking at here is the scanning more than the PSA. It's really the scanning more than the PSA that indicates when we get on and when we get off, I would say. And if it were me, I'd be relying a lot more on the scans than I would. And, you know, when you don't see very much going on in the scans, I think that's sort of comforting.
I think so. And when he was very careful to quiz me about how I feel, where I am mentally. You know, does the number scare me or doesn't the number scare me? He says, and we can treat it both ways. It really depends on you, David. So we talked about different options, and I am good being on a drug holiday and living another 3 months drug-free. So that's really my decision. I just want to bring everybody up to speed, and we'll see where it goes. But I was shocked that it dropped. I wasn't
David, he's
expecting
following
that.
you, just PSMA, pure PSMA, no FDG, just PSMA. Is that all you're getting?
Correct, F18.
Yeah, well, I'm a little confused because my consultant up north said to me, I want you only to get an FDG if you get your PSA.
Well, I think the reason for that, Jack, we've really got to move back on. We can't keep coming back to you. But the reason for that is because he probably suspects you don't produce very much PSMA. We could never find any PSMA in you forever and a day, and your PSA is very low. So what's the point of doing a PSMA scan for somebody where we could never find it in the first place? So that's why he doesn't want you to do a PSMA. But I'm moving on. I'm moving on because I've got to keep going here. Jim Marshall.
Yes. Let's see. A little history here because I don't talk much. Let's see.
Hold on just 1 second, Jim Marshall.
Okay.
Anybody else want to say anything to David about David and his holiday before we move on? I don't want to shortchange David. Okay, we're moving on to Jim Marshall.
Okay. this is going to be a Kaiser story. Okay, 2017 diagnosed Gleason 3-4 metastatic seminal vesicle invasion. Latitude study just closed, got on to Lupron plus the abiraterone immediately. And they knew it was in one of the lymph nodes in the back, possibly two. 4 years and 10 months later, I decided to take a holiday. I stopped the Abbey first. 3 months later, I stopped the ADT Lupron. Been on the holiday now for 27 months. Started to PSA has just started to creep back up. It's been 0.06 for about 90 days. And I started to lay the groundwork for trying to be referred to a GU type within this area. I got turned down, but I got offered NIH has a Dr. Ravi Madden to go there. And I looked him up, and it looks like he is a researcher trying to figure out how not to use ADT. Now, the genesis of all this is I was asking in the future for a PSMA scan to find out how many METs I possibly have. I know I've got one, possibly two, but I don't know how many more, which might affect whether I go back on just the ADT plus the Abbey or I do something else. And so it seems Kaiser is adverse to doing PSMA, and they offered me a CT scan and a bone scan, with the provisions, if they don't find anything in the CT scan, I can get a PSMA scan, but I already know they're going to find something in the CT when they say, when they see one of the lymph nodes is probably still puffed up. So as I said, at this point, we are going back and forth.
So my 2 cents, whatever it's
Okay.
worth, is that I wouldn't accept Dr. Madden. We are not particularly impressed with the standard of GU medical oncologists at NIH. As some of you with history here know. And particularly if they have if there's something they're investigating, because they seem to forget about the patient and concentrate on what they're investigating, and we've seen it.
Right.
And it hurts.
Yeah.
And it hurt us at AnCan, and I don't want to see it hurt us anywhere else. I would say this: keep pursuing with them, appeal it, keep pursuing. Try and get your ass to Channing Pala. You can also tell them that, and you'll find it in the NCCN guidelines, that PSMA scans are recommended for maintenance, and
right.
and just the fact that it shows up on that something might show up on a CT scan, and I don't know what sort of CT scan, if that's an FDG PET or what. But the standard of care today is a PSMA scan. That's the standard of care. And you use those words, right, and you go fight them, and you're good at that. You're very good at that. It's right in your wheelhouse. And I wouldn't accept if it were me, I would not accept a Dr. Madden at the NIH.
The only thing that I might try is if I can get essentially a PSMA PET out of them for free, I might do it. But other than that, no, I would
Well,
not
I,
accept them
I've got a
as
better idea. Why don't you
lifelong.
go get a PSMA PET from the VA?
Well, that is plan B, but I figured I wanted to shake the tree over there
No, but
because
Jim,
down the
once you get
road,
no, because once you start messing around with Madden, then they're going to put you off and say, but we sent you to Madden. Don't even
oh,
go
okay,
there with KP. And
okay,
you can get a PSMA scan out of the VA, and
right,
that's not going to affect anything. So if you
right.
want that PSMA scan, screw Kaiser, and go to the VA. In fact,
I am
why don't you
thinking
get
about that.
yourself a community health referral to Dr. Pala?
That
And
is the plan, but I figured at least to give them a try to see if Kaiser would spring for
well, they
PSMA
won't. So
in
we
this
know we
area.
know they won't. We know they won't. Who's got some comments for Jim on
I
this
just have one quick
situation?
comment, Jim. I know for a fact, as recently as last 6 months, Kaiser Northern California has lowered the barrier for PSMA PET. They don't argue about it.
Right,
They go click, click, and no problem. So I don't know
right,
what's going on in DC.
right. As I said, I just started this about two days ago. And so, as I said, if it gets too tense, then yes, I already have plan B, or I can do TRICARE for life,
Yeah,
plan C. So,
good.
anyway, so as I said, I'm still at 0.06 for about 90 days. And actually, the PSA has gone up, it's gone down, it's gone up, and it's been stable now. So,
Yeah, but
anyway,
again,
good news.
we don't. It doesn't mean a lot at 0.06 if it goes to 0.08. So let's not talk stable. It goes up, it goes down. It just doesn't have a significance, Jim.
Right. At this point, yes.
It's
So
too low to
if
be
it does, great.
significant. All right, now we lost. It looks like. Thank you, Dr. Alfredo. Anybody else have anything for Jim Marshall? But you got two plans, and don't bang. Don't bang your head against a wall. Take the easy route with TRICARE for Life or the VA. For goodness' sake, you deserve it. You do enough for others. All right. It looks to me like Dr. Jeff and Doug Wilson are not in the room right now. Oh, wait a minute. Somebody is. Dr. Jeff is in the room. Yes. I saw you
Excuse
leave,
me,
but
Rick.
you snuck back in, Dr. Jeff. Go ahead. It's your floor.
Excuse me, Rick. Doug has his hand up.
Oh, and
He
Doug
does-
is in the room too. Okay, when then we're going from Dr.
no,
Jeff and then to Doug Wilson. Dr. Jeff, you're up next.
no, Doug DeFries.
Oh, Doug
DeFries.
DeFries. Doug DeFries. Sorry, Doug. Go ahead, please.
I didn't understand that a PSA PET scan would track anything at a 0.06 PSA. I thought you had to have higher PSA than that to make it
Well,
effective.
again,
That is true. I was planning for the future to see if it is possible at the appropriate time.
okay, but it
Right.
may show
So,
something now. It may. Here's the thing. Using a PSMA scan to detect cancer when you've never had metastasis before, you need a certain level. But if you had metastasis before, and those metastases might be dormant or what have you, that they may still express PSMA. You may not be expressing PSA, but you could be expressing PSMA. It's not usual, it's not normal, but just because you've got a low PSA doesn't necessarily mean we won't see something on a PSMA scan if we know you have a heavy tumor burden.
So the goal is to, in addition to the known metastases, to see if are any others.
Right. That's what Jim is looking for. And I mean, probably the reason they don't want to give him a PSMA is because they say, well, his PSA is low. And yes, there is a correlation between PSA and PSMA. We know that. But there are also people with low PSAs like Mark Valens who lights up on a PSMA scan. So it's not for sure. And the, you know, this whole story, this whole concept of needing a certain level of PSA before you see anything on a PSMA scan is really only appropriate for people who where we're looking for these metastases for the first time or very early on. I mean, look, you know, David Muslin, 0.5. What are we doing? We're looking at PSMA scans every time at 0.5. That's how Dr. Shmulewicz is managing his cancer.
So is it true then that once you have had a PSMA that or a PSA that is higher, then there's a good chance that if you do have a metastasis, that'll still show even though your PSA has gone down. Maybe because your PSA went down because of therapy, ADT.
Yeah, I mean it is because the cancer's still there, and it's still making PSMA, and it may still be making PSA. That's, you know, that's a little above my pay grade, I have to tell you. I mean, this relationship between PSMA and PSA, I don't know. What I do know is we can see lesions even with low PSAs where we have men who have a history of tumors of tumor metastasis in their bones and elsewhere.
Thank you.
Now it's your turn, Dr. Jeff. Don't tell me we can't hear you. You're not muted. You're not muted, but your mouth is moving and nothing, and we don't hear anything. I don't know what's going on. I don't know.
He's telling you move on.
Oh, move on. We'll move on and come back. Go out, come back in again. We'll go to Doug Wilson. Where's Doug Wilson? Is Doug Wilson around? Okay. Doug Wilson may have left. We're working on Dr. Jeff to get him back in. We're going to Al Latimer.
Hello, everyone.
Hello.
I don't know if there's anyone else in the group tonight that sees Dr. Schulz or not. I've been seeing him mostly virtually the last couple of years because I'm on the East Coast and he's on the West Coast. I got an email from him today that Medicare is not going to accept telehealth anymore, and that I'm going to have to start paying for it out of pocket. So I don't know if any of you have do telehealth with your doctors, but apparently it's going, excuse me, it's going to change in 25. I just wanted to bring that up.
So I will write about this a little bit in the next reminder, but telehealth provisions are changing in 2025. For the last 3 years, we've been trying to get telehealth extended. It was a major advocacy point, lobbying point for the AUA. But what a surprise. They didn't get it. They didn't get anything done. Just like every time the AUA has a lobbying point. they never get anything done. That's why they threw me out. They didn't throw AnCan out. They threw me out because I kept reminding them that they're better off trying to focus on what they can get done and not what they can't get done. And in fact, what has happened is that in most cases, you're not going to be able to get telehealth covered by Medicare for the coming year. So you're going to have to work out with your doctor how you're going to see them and how you're going to deal with that. And could be a telephone call that they bill you for differently. They don't call it telehealth. I don't know. This is going to be an evolving. We've sort of gotten kind of used to this telehealth thing. I mean, there's a lot of people in this group who are using telehealth, and I think about Mark Valens going back up to Oregon and then speaking to his docs, and Mark's definitely qualifies as being in a rural location. And I don't know how they're going to handle it at this point in time, but we'll find out, Mr. Latimer.
Well, in Dr. Scholl's case, I mean, he's independent. He gave me a schedule. 5 to 10 minutes is going to cost me $225. 20 minutes is going to cost me $375, and 30 minutes will cost me $525 out of pocket. That's their plan come 2025, which is still cheaper than flying across the country to see him. But I got used to Medicare paying for it, so it's going to be a little shocker.
So you're the accountant around here. You're the CPA. How much is that a minute?
I don't know, but it's $1,100 an hour. Divide that by 60. You tell me.
Okay. Like I said to you in my email, maybe I need to get a stopwatch, and I can charge the similar rates. I'm thinking about it. I don't know what to say. I do think it's a work in progress, and I think they're going to come up with some things. I don't know exactly what yet, but watch this space, and anybody who can contribute, please do so. If you talk to your docs and they start telling you about what you're not going to get with your Medicare, please let us know.
Well, if you're with an institution, like I also see Belusic in Miami, I'm sure Belusic's going to tell me I just got to come down to Miami if I want to see him, I would assume.
And, there are people that do that. There are people that do that right now. And, if you're out of state, you've got to move into state. Well, I think Mr. Valens has been known to drive a few miles to cross the Oregon-California line so he can make a telehealth call. Isn't that true, Mr. Valens? You're muted.
Yes, the UCSF sometimes requires you have to be in California for them to give you any advice. So luckily we're only 10 miles from the border. So.
Well, you don't have any border problems, Jeff Markey. You're dead central. What's your advice on telehealth?
This is true with Medicare. I have never seen Harstark. I have only talked with her over the phone or on video, and this has been going on for 6 years now. So how was she getting paid before? Is the Medicare Advantage different? Is this just state lines we're talking about? Because
we're talking about now is that Medicare will not cover telehealth. So if Kaiser wants to bill Medicare for an appointment with you, on telehealth,
I don't think they consider it in telehealth. I think they must call it something else.
Well, that's what I was saying before. Maybe they'll call it something else. But if they do consider it telehealth, you're not rural enough. You've got to be a lot more rural than you are, and it's too easy for you to get over to Geary, so you'll have to go see her in person.
But they've always had it so that I could talk to her on the phone.
Well, but
even before
always is going back to COVID. Did you
no,
try?
No, I'm talking about 6 years, way before COVID.
No,
I
you're
was getting it
not.
for free.
You didn't see Andrea Hartstock before 2020.
Yes, I did.
I don't think so. You
Look at, I absolutely know for sure because I first started seeing her when she was in Oakland.
Right.
And that was a long time ago. It's 2020 is not even, I mean, it's way after I started seeing her.
Okay.
So I
well,
know I've been getting free
The
phone
other
calls.
possibility is it's a managed healthcare system. This is where Dr. Alfredo comes to our rescue. It's a managed healthcare system, Kaiser. So they may be able to get around the Medicare rules. They may be able to skirt those Medicare rules in your Advantage plan. I don't know. Is that possible, Dr. Alfredo?
It's possible, but I think one of the issues here is we still have our medical licenses from the state that we're in. Some of us have a medical license in multiple states. And I believe that the companies that offer national telehealth, 1-800 talk to a doc kinds of places, they route you to a physician who's licensed in the state you're calling from.
Right.
So the business about driving over the California border sort of makes sense to me in that light.
Right.
Now, they may have loosened the rules somewhat in the last few years, because we see now we do everything online. But years ago, there was no way you were going to give medical advice across state lines.
Right. Now, what about, though, with a Medicare Advantage plan? Does it have more flexibility? If Medicare says we won't pay for telehealth anymore, if it's an Advantage plan, is there more
Advantage plans have a
flexibility?
lot of flexibility in terms of what they do. But remember, just like every other insurance, an Advantage insurance plan is licensed by county within the state. So a Medicare Advantage plan might very well say, like the one I have, for example, says, "Oh no, you live in the wrong county. You can't be a member, so you certainly can't get services. You can pay fee for service, but the insurance arm is not going to pay for it."
Okay.
So it's complicated. So if you have a plan that offers telehealth at all, great, take advantage of it. I know that for my wife and I, it works very, very well here in Texas. We used to use it in California. It worked fine. But the other alternative is these national companies, of which there must be a dozen at least, that you call an 800 number and it routes you to a doctor who's licensed in your state. I cannot speak to the quality of those, like Teledoc. I can't speak to the quality, good or bad, about those.
Okay. Well, we've got. I'm gonna move along because I think there will be a lot more about this. Gary Peters, you wanted to say something, and then I'm going to Dr. Jeff.
I just wanted to say that for a telehealth appointment with Hopkins, I have to drive into Maryland. And for a telehealth appointment with Inova Fairfax in Virginia, I have to drive into Virginia.
Okay. All right. And how do they know? How do they know?
Well, they don't. But I'm anxious enough to have those appointments that I'm afraid to take the chance.
Okay, well, what I think you need to find out is whether you're going to even be able to do that for telehealth this coming year.
Right.
Okay. David Muslin, and then I'm going to go to Dr. Jeff, and then I'll come back to Jimmy and anybody else after, because we're right at the witching hour. David Muslin.
I was going to ask the same question you just did. How do they know where you're at? But that's an individual decision.
Right. Okay. So, Dr. Jeff, can we hear you?
I don't know. Can you?
Yes.
Oh.
Yes.
Okay. So Gleason 9 spread to the seminal vesicle. I'm finishing 16 months of Lupron and abiraterone and prednisone. 8 months left. and I'm definitely Cushingoid from the prednisone. Been told I have a moon face by 3 different people. Never had that. Always had a long, thin face. So the steroids are giving me Cushingoid effects. But my last PSA holds good at less than 0.02. So whatever these side effects are, I'll live with them, and continue Lupron and abiraterone and prednisone, hopefully for 24 months. Keep doing the exercising and hope for the best. I saw a commercial on TV, Rick, the other day for EmberWave. It was a 2-minute commercial. Not one male was in the commercial. It was all females and postmenopausal stuff, but no men. I think they need to rethink that.
We've tried. We tried to get sponsorship from them. We've tried to push the envelope, and we don't get anywhere. So, if somebody else wants to write to them and tell them, that'd be great. But I got to tell you, I'm not spinning my wheels anymore.
Bad marketing.
They were not grateful to us. We really helped them. We pulled in almost 30 men for them to do their trial, and we didn't get a dime out of them. So, as they say in the classics, we got high cuck. So,
I've been in one of their TV commercials. I have not seen it, but my neighbors have, and they kept telling me I've been on TV.
Oh.
And they remembered the ad. It was AnCan.
I want to catch Len before we lose him again, and because he's right here. Don't go away for a second. Is there anything else for you, Dr. Jeff, other than telling us you're doing great? Are you exercising, Dr. Jeff?
I do. And
okay.
And to be honest, anytime I don't want to exercise, I think of Jimmy G, and I go ahead and exercise. So I take my non-existent cap off to Jimmy for pushing all of us to do our exercise.
Thank you. Okay. But it's a good report, and I'm glad you are where you are, and we got your back for the next 8 months, and then you're going to be done.
Hopefully, yes.
And with a continuing durable remission, as Snuffy used to call it. Len, I want to go back to, because we lost you at a key time. I want to go back to this discussion about when you're on a holiday, how much weight do you put on PSA and how much weight do you put on PSMA scans or other types of scans? Because you are the expert and the master at that.
Well, only through experience, not knowledge. But
no.
So what we've done, what I've been doing with Dr. O for several years, is a CT scan every 6 months at the latest, whether or not the PSA is moving or not. Usually, if it's not moving, just to be sure there's no radiographic progression without PSA progression. Because I do have a history of sprouting new metastases at very low PSAs, like 0.17 most recently last year. Does that answer the question?
So what type of CT scans are these? Are these FDG PETs or what are they?
No, just, I mean, if the PSA reached 0.2, which at least historically, I'm not sure what it is now. Historically, that was the cutoff point that insurance would pay. Then we would do a PSMA. But if it was below that, we would just do a CT scan with contrast, with and without contrast.
And if you're over 0.2, then you'd go to a PSMA scan.
or at 0.2. Yeah.
Or at 0.2.
Yeah.
And what about when you got to those higher levels, like when you're pushing the envelope to like 2 and before you go back on treatment?
Well, I haven't been at 2. The last time I was at 2.4, that was 2019. And that's when I entered the clinical trial for the PSMA PET scan because Axeman wasn't showing anything, CT scan wasn't showing anything. So I really had no choice but to wait for the opportunity to get into a clinical trial for the PSMA PET. But, you know, after that test that showed metastases, I was on darolutamide. My PSA has never gone beyond 0.2 in the last 5 years.
Okay.
I wanted to ask Dr. Jeff just quickly, did you consider getting away from Abby and the prednisone with darolutamide or something? Because now that you have these Cushingoid side effects, maybe that's an excuse for them to approve darolutamide for you.
So I'm gonna see the oncologist next Friday, and let her look at me, and then see if she'll approve getting away from the prednisone and the abiraterone.
Okay, good.
And going on a blocker, a enzyme blocker.
Right. So yeah, I'm sorry I missed David. I assume I missed David Muslin's discussion about his PSA stabilizing. Did anyone else besides me have that stabilizing experience? No, I was the only one. Okay.
I don't think anybody sort of said, no, we were stable for a long time. We knew you were, but you disappeared at that point in time.
Yeah.
But what we did say to David and what he's doing is you just got to stay on top of it with the scans, whether it be CT scans or PSMA scans. In David's case, PSMA scans.
Yeah. Yeah, if they'll approve it, of course, do the PSMA. If not, the CT scan will, or an MRI scan will show whatever might be there. The only thing is you'd have to have a comparator with the CT scan, the MRI. They need to compare to see what if there's an interval decrease or interval increase in the size of a lesion, because with CT and MRI, you're not sure if the lesion is active or if it's sclerotic from previous treatment.
David, go ahead.
I was just going to comment on Lynn's comment to Dr. Jeff. I was on Lupron and doublet therapy for 19 months, and then when I went to see Dr. Shmulowitz, and I wasn't feeling well, so he said, why don't you try Dara? And I was on Dara for 18 months then, and then I took a drug holiday. Just an FYI, Dr. Jeff.
I got to tell you, with this Cushingoid moon face, I'm having trouble distinguishing between you and Peter Monaco. I think Peter left right now, but I have to look twice and see, is this Dr. Jeff or is this Peter Monaco?
He's still here.
I'm still here.
Oh, you're still here. Look at it. Look. Yeah, you could be brothers. Look at the two of you. Look. So, Jimmy, you've got something you'd like to say.
It's not going to take long. It was under the discussion of the telehealth and the state lines. I had a Hopkins doctor. I told him they told me that I couldn't have a telehealth visit with him because I wasn't in Maryland. I was in D.C. And he said, "Do you have any friends in Maryland?" I said, "Yeah." He said, "Just use their address." So yeah. I still made the call from home. It basically was saying, don't worry about it.
Yeah.
So you didn't hear it from me. You heard it from my doctor.
No, I think there's going to be a lot of and to answer Tony Figg's question, Would e-doctor portal visits be affected? I'm sure they will be if you're paying for them with Medicare, Tony. If you're paying for them with Medicare, you're going to be restricted. So everybody who's on Medicare received a 2025 Medicare pamphlet, which I see Al Latimer just happens to have handy. Mine's in my file cabinet. Look, he's holding it up. Look in there. The rules and regulations are in there. I'm going to probably use Al's picture that he took of that page. I'll give you a reference and a page number in next week's reminder. But that's what Tony Fig, that's what you got to go look at, man. And look and there's a little section on there until 12/31/24 you can do this. After 12/20/25 you can do that. And yeah, I mean, we're gonna be we're gonna be dodging and weaving a little bit, I think, on all of these issues. I don't know what Dr. E's gonna do because she loves those telehealth appointments. Yes, Mr. Latimer.
So I have a telehealth appointment with Dr. Belusic this Friday. I'll ask him and see what UM's doing about it.
Yeah, please. I mean, we this is how we're gonna know when we hear from different people how they handle things. All right. It's only 8:12. We're pretty much done. Did I miss anybody other than Doug Wilson, who left early? I guess not. So, Jim Marshall has his hand up again. Go ahead, Jim.
Yes, I have a question for Luther. Are you a veteran? Luther, I see you're still.
Yes, sir. I am.
You are. Well, then you can also join us too.
I think you have a meeting tomorrow, right, Jim?
That's
yes,
right.
There is a meeting tomorrow night. So, did you see my email address within the chat?
You sent me a notice.
Okay.
Oh, I already did?
Yes.
Yeah. Oh, good. Okay.
No.
Well,
Luther's on the reminder list.
oh, good. Okay.
And
Well, then hopefully I'll see you tomorrow night.
And you've taken care of getting the reminder to Bob Schwartz for tomorrow, correct?
Yes, already there.
Thank
Bob,
you.
you should have it already.
All right, guys. Listen, we're done, and we'll be back next week with Ben Nathanson back in the second Tuesday, the regular second Tuesday slot. And I never even gave a promotion to our survey. Damn, I meant to put that in, pin that at the top. But yes, if you haven't done the survey, please do it. Is there anybody here who hasn't done the survey? Nobody's going to put their hand up for that one. Oh, Larry Schuler, okay. But you need to do the survey. We've sent it out to everybody. Okay. Oh, and look, David Keller lasted the whole meeting. Oh my gosh. All right, that's it. I'm shutting off the recording.
Good night, everybody.
Good night.
Good night. Good night.